Okay. Right, I think what we're going to start. So, do you have access to blood gas machine to your place?
Not all the locations, but the central ones, they have it.
The central ones.
Yes.
Okay. And okay.
Unfortunately, I've been working for 2 years.
Yeah.
I haven't seen ABG machine yet.
Really?
Even I haven't seen it, but I have seen the result.
Yeah, yeah.
Including the results.
Yeah. Oh my god.
Yeah.
Hospitals of Iraq, most of them, they are not present, but in central hospitals in Suleiman, they are present. And in the ICU.
In ICU, yeah. Most ICU, or almost all ICUs, they have blood gas machine. But do they do blood tests for you as well? I mean, if you have a patient in the ward or any.
Yes, they do it.
During COVID ICU, when you had a patient, we sent for their blood tests, and we saw the result just.
Excellent.
As far as it has indications, I think they done it here.
Yeah.
It's not related to the ICU. Even the stable cases in the medical ward, they're gonna do it daily.
Yeah. But that's at the ICU. There's in the lab.
They're gonna take the sample and then they do it in the lab.
No, in the ICU. The machine is present in ICU.
Oh, no, not in the lab.
Also in the open heart.
Huh?
During open heart
Yeah.
surgery.
Oh, they have to. They can't open the heart without doing that. Okay, so basically we're going through some scenarios, the easy one or simple one. I'll just remind you of the basic of blood gas analysis. Okay, and hopefully it probably cover the majority of cases you're going to see in the ward, in A&E, in the ICU, even theaters. Okay, so we know the probably roughly the normal figures of the pH and PCO2, PO2, Bicarb on the base. Okay. Now there are different approaches to analyzing or interpreting the blood gas machine. What I usually do, I don't. Some people will say, okay, if the pH down and the HCO3 down, that's metabolic acidosis. If that down and the CO2 up, that's respiratory acidosis, and so on. You can obviously remember it like this, but it's I think it's confusing. If you want really to master your blood gas, you have to understand what's the acid, where's the acid, yeah, what's the pH, where is the acid coming from? Is it from metabolic element or is it? There's the only three variables here, as the pH, the respiratory element, and the metabolic element. So it's as long as you analyze it in your head, it shouldn't be a big deal. Okay. Now, I'll probably go with a scenario and then ask you to interpret this. So if the patient pH is 7.2, PCO2 3.3, PO2 14 on 2 liters, and HCO3 15, base -8. Okay. Now, if I ask you two to analyze, what do you think this
So
blood gas looks
first of all, we have low pH, so this is acidosis.
So this is acidemia, okay? Yeah,
Next,
that's acidosis. We
Yeah.
call it,
Next, we look at the
elements.
the
Yeah.
PCO2, the element. We see it's low.
Which one?
PCO2, it's low. It's
So is that
3.3.
okay?
So it can't be respiratory.
Yeah, it's not respiratory.
Okay.
So we agree on that.
And we look at the bicarb. So
Yeah.
it's also low, which means the base is low. So
Yeah,
it's metabolic
the acid
acidosis.
is high.
Yeah,
It's
that's-
of
So it's metabolic
origin.
acidosis. Okay, and this base is -8. Now, how are we going? What do you do with this patient? How are we going to approach this patient?
we
Okay,
agree.
he's 65 years of age. Suffers from Crohn's disease. He had total colectomy with ileostomy, and he's been having high output stoma. and came in. Well, he's in hospital.
Mhm. So I'll give sodium bicarb to try to treat the acidosis
Okay, why sodium bicarb?
because it's base.
It's
So
deficit.
Okay,
There's,
Replenish.
there's metabolic acidosis.
okay,
So there's diarrhea could be, or loss of the
Okay.
as a loss of the base through the GIT. We're
Okay.
gonna replace it.
okay. So if I tell you lactate is 8, would that change your view?
This is the range on the other column, right?
Minus
Lactate
Yes.
is less. Where is it? Less
Oh,
than
this one.
no. This one and this one. Yeah, less than 1. Lactate less than 1, and the base is plus minus 2. So the you probably answered correctly, but I probably will ask for more details of this patient. If I told you this patient is suffers from high output stoma, his blood pressure is 130/80, and his heart rate is 80, his capillary flow is normal, his respiratory rate is normal, and his saturation is 98, then I would say, okay, there's no hypoperfusion. I'm not suspecting hypoperfusion. And what's happening here is, as you said, he's losing his sodium bicarb, so I probably need to replace that sodium bicarb.
Yeah.
Okay? Now, if I told you another story, well, he's 65, he's losing this high stoma output, and he came in with blood pressure of 90/60. Yeah, his heart rate is 140, his capillary flow is 5,
okay, so this is
But
hypoperfusion and lactic acidosis.
hypoperfusion, hyperlactemia. Okay,
Yeah,
so before we reach a conclusion whether to give him bicarb or not, I probably will ask for more details. Yeah, and in order to do that, probably I go and approach the patient in ABCD. Yeah, and then assess him, see how his breathing, his airway breathing, circulation, and if he's, everything is normal, but he's that's low, then probably bicarb. But if he's hypoperfusion because of dehydration, that's a different story. Okay, right. Let's have another.
Can it explain DKA?
Huh?
Can that picture explain DKA?
DK.
Yeah.
Yeah.
So the same thing.
Yeah. But then you ask for another question. What's the lactate? What's the blood sugar? Where's the acid
Yeah.
coming from?
Yeah.
Doctor, I basically have a lack base on the acid-base disorders and ABG analysis. So could you please
Yeah.
explain
No.
roughly the base
We
of-
will do few sets, and then you'll pick it up. Where's the? Okay. So let's establish the approach. Okay. You interpret these blood gas as part of the whole patient picture. Okay. So the clinical observation, vital signs, and the blood gas and other blood tests, and with the history, obviously good medical history. So I'm having this 20 years of age girl, 7.10. No, maybe 4. Okay, so this, that's for you, yeah. So this is a 20 years age a girl who suffers from diabetes, insulin-dependent diabetes. Okay, it came in. She hasn't taken her medication for a few days now. She came in slightly confused, little bit tachypneic, blood pressure on the lower side, like 90 systolic, heart rate 140. Okay, and we've done some blood investigation, and we have this set of blood tests, or blood gas, I mean. Okay, so what you look at the blood gas, and you look at the blood gas and then relate it to the patient medical condition. So we look at the pH. pH is low, so she's acidotic. Yeah? And acidotic, acidemia. And she's trying to compensate for that with hyperventilating. Yeah, so get rid of a lot of acid, which is CO2, to compensate for the acidosis. But obviously that's not working. Yeah? As part of the acidosis, she's losing a lot of bicarb. So it's, instead of 22, it's only 4. Only 8. And there's a minus 17 base deficit. So what this picture suggests?
This is
Yeah, it suggests metabolic acidosis. It doesn't suggest ketoacidosis because we don't know where the acid comes from. So it's metabolic acidosis. Okay? Now, why lactate is 4? Because if we agree, we take it further and we did the blood sugar and the ketone is high. So we establish a ketoacidosis in this girl who missed her insulin. Why lactate is high? What's happening here? Is the acid only coming from the ketones or coming from lactate?
It could be lactic acidosis.
And why is coming from lactate as well?
So she is hypoperfused.
That doesn't answer.
Yes, because of the respiration, she's healthy and she's not breathing properly. So no.
No,
So,
because
yes.
lactate is metabolic element.
Yes.
Okay, so she's tachycardic, blood pressure is low, and she's losing a lot of urine because of the uncontrolled blood sugar. So what she ends up with hypoperfusion
Yes.
in addition to the ketones. Because of hyperperfusion, she's accumulating lactate. So this is a metabolic acidosis, acids coming from the ketones and lactate. Okay. Now, let's go and measure. How do you treat this patient? Apart from the ABCD approach,
Hydration.
let them answer. How do you treat this patient? So diabetic ketoacidosis, 140 heart rate, 90 blood pressure, so hypotensive.
Rehydration.
Rehydration, lots of fluid. Yeah? Normal saline, and insulin.
Yes.
So that's hopefully will correct a lot of this acid because the girl will not produce any more ketones, and because the fluid also will clear the lactate.
Can we keep the normal high rate respiratory rate? It's okay.
It's okay, they compensate until when this goes to when that becomes 7.2, this will come down. She will ease a bit. So it'll be 3.5. Okay? And then it will ease because she doesn't need to compensate that much because her acid or acid-base balance will be more corrected gradually. Okay. Now the question is that how do we know when to give bicarbonate or when not to give bicarbonate? Okay. In metabolic acidosis, when to give bicarbonate and when not to give bicarbonate. Obviously in here in diabetes we don't give bicarbonate, only if this goes below 7, like 6.8, then probably will have to give. But the concept of anion gap comes into the picture. Okay? So what's the anion gap? Is the sodium plus potassium, the cations, minus chloride plus bicarb, the anions. Okay? And we have 3 types of metabolic acidosis. There's the high anion gap, the normal anion gap, and the low anion gap. The low is probably not that common, but it's mainly the high and the normal. With the high anion gap, there's an acid Yeah, there's an acid in the body, like in this lady, ketone, and that acid consume all the bicarbonate, and so that's why it's becoming acidosis. So there's not a problem with bicarbonate, the problem is with the acid. So you don't give bicarbonate, you treat the acid, okay? So if it is lactate, you treat it with hydration. If it is ketones, you treat it with insulin plus hydration, okay? That's while if it is renal acid, you treat it with dialysis or hemofiltration, okay? While in other reason, in normal anion gap, the problem is where
In the bicarb.
in the bicarb. So you need to give bicarb. Okay. Now I'll give you this example. Okay. Now, this is a lady who had cholecystectomy done. Okay, complicated a bit with infection, so stayed in hospital for some time, and she was on IV fluid for probably a week. Okay, and then her blood pressure is fine, 120 or 70, little bit tachypneic, capillary fill is okay. But she's a bit tachycardic. So we've done blood gas on her, and there's this set of blood gas. Lactate is normal, not a problem. Okay, but she's acidotic. Or maybe you too, if you like to, yeah.
The pH is 7.2, so it's acidosis.
Yeah.
The PCO2 is low, so it's not respiratory. The HCO3 is 17, so it's metabolic acidosis.
Metabolic acidosis. Okay. Now, if the, yeah.
Respiratory compensation.
Sorry.
No, there's no. It's just the metabolic acidosis.
Yeah. So where's the? How do you treat this? Where's the acid come from? Lactate is 1, so it's not hypoperfusion, not hyperlactemia. Lactate is normal. Okay.
What's the restriction?
So we'll do. What's that?
Oh,
أنا
so
قاعد بكتبه.
could be because of she
Yeah.
has the
Let's do an
area.
anion gap, shall we?
Yes.
Let's do an anion gap. So sodium is 138 plus 5. Yeah.
43.
Yeah. We know the bicarb, which is 17. Yeah. And
Yes,
132. 11. What's the normal anion gap?
10 to 14?
Huh?
10 to 14?
10 to 12. Yeah,
10
10
to
to 12.
12, yes.
That's
هذا
fine.
normal أنا عندي.
Normal anion gap.
So the
Okay.
problem is with
With bicarb.
Bicarb. Now, if I add to the history and tell you she's been, well, I'll tell you this. She's been in hospital for a week on IV fluid. And our clever surgeon giving normal saline. That's causing her chloride to be up. So that's causing hyperchloremic acidosis. Okay. Now, why she gets, what's wrong with the chloride? The chloride is absorbed preferentially with the, and the kidneys get rid of the bicarb. So the chloride absorbed, and the bicarb goes. That's why causing hyperchloremic acidosis. And the message here is that in the post-op patient and in patient in hospital in medical ward, we don't use normal saline. We use normal saline for resuscitation only, and because of that, yeah. her tachycardia has nothing to do with dehydration. It's nothing to do. It's to do with the acid, and the acid is not good because it's caused the myocardium to be a little bit ineffective in contraction, because the myocardium used to use a pH of normal pH. Okay, so that's the importance of anemia. Okay, right. What time is it now? Shall we do another one? Do you have time for?
4:17.
Huh?
It's 20 past 4.
Okay, so we still have.
I
Yeah.
don't know when the session ends.
5 o'clock? No. Yeah, because I need to go through some
Okay.
what you call
I
it,
think it's
ECG.
the last session, so
This
we
is
can
the last
take
session,
our
yeah.
time.
The last session. No,
Any
we're
issue,
having another session for the whole team.
Yeah,
Oh,
we
okay.
got
Yeah.
no, next session. No.
There's another session. Yeah. Okay. So 7 point. Okay. So
Because pH is low.
yeah,
Acidemia.
yeah.
So CO is normal. Low.
CO2.
Yes. Bicarb is high. It's
No, just back. Acid.
acidemia.
Yeah. CO2
CO
6.8.
high.
Yeah. If you see that, it's
Yes.
4.5. So it's a lot, very, very high.
Yes.
Yeah.
High. Bicarb is high.
So before you go to bicarb, where is the acid coming from? Where is respiratory acid?
Yes.
Yeah. But there's some compensation happening, not achieving much. Yeah.
Yes.
So this is a respiratory acidosis,
Partially compensated respiratory acidosis.
partially compensated.
Respiratory
Okay.
acidosis.
Now, if I tell you there's lactate is 6, would that change your views?
The medical background about the patient, we need more, I think.
So it points toward the respiratory depression.
Okay. What do you think? Would that make you think of another mechanism or another cause for acidosis, not only respiratory? Okay. So if I tell you she's a 70 years of age patient, 70,
Okay.
long life smoker, severe COPD.
Tumor marker cancer.
Huh?
Cancer.
No, don't go that way. So 70,
Okay.
long term or long life smoker.
Okay.
Yeah. She came in with abdominal pain. Okay. And her blood pressure is about 100 over 60, and her heart rate is 120. Okay. So if you analyze the whole picture, you would say, okay, she's a COPD patient, long-term COPD. So probably she's somebody who accumulates CO2,
Has CO2
Yeah.
retention as herself.
CO2 retention, and compensate that with high bicarb. So in fact, this lady, her normal CO2 is 8. Yeah, and her normal bicarbonate is 40. So now my thinking has changed because of the lactate, I think it's metabolic acidosis. And she's compensating by hyperventilating, washing the CO2 from 8 to 6.8. Yeah? So basically, this lady is used to high CO2. Yeah? And with high CO2, her pH was 7.3, normal. And the bicarb is 40. That's why she's going. Yeah? Now she gets infection in her tummy. Yeah? Hypoperfusion. acid accumulates and eats a lot of bicarbonate. So instead of 40 goes down to, yeah, and then the lactate climb up because of the hypoperfusion. Okay, so that's a metabolic acidosis not compensated by respiratory, or basically combined, but the main element is the metabolic. So there's a metabolic element which dominates the acid-base balance. Is that okay? Yeah.
So what
Yeah, I
was-
know it's not easy, but that's probably yeah.
That elevated lactate will explain the situation, you mean?
Yeah, the hyperperfusion.
Hyperperfusion.
Yeah, and the
Okay.
metabolic element of the acidosis. Yeah,
Okay.
because lactate is an acid, and lactate comes from hyperperfusion or sometimes liver dysfunction, but hyperperfusion almost majority of cases.
If lactate was normal, then we
Yes.
thought we will thought about we will thought
Respiratory.
about respiratory
Yes.
organ.
Yeah.
It's very tricky. It's all I can't hit the because there's a lot of stuff.
Okay. You two, you both of you attempt this. Okay. So
pH is low, so acidemia.
severe acidosis, yes.
Acidosis.
Yeah. Where this acidosis coming from?
CO2 is high.
Yeah. So that's the main acid there. It's 8.5, very high actually. And the patient is compensating, but is not achieving much. Yeah. So if I tell you this patient, 70 years of age, a lady, heavy smoker, been unwell with dry cough for a week, and then come to hospital. Yeah. She's confused. Blood pressure is about 100 over 60, and heart rate is 120. So
Respiratory failure.
yeah, respiratory failure caused by chest infection, pneumonia. Why? What's the cause of confusion?
Cerebral
Hypercapnia.
low O2 level due to
8
hypoperfusion.
Hypoxia.
CO2. Yeah, hypercapnia. Yes, because you don't expect her to have PO2 more than 8. Yeah, but that's high CO2. That's causes confusion. Yeah. Okay. Okay. Shall we do some ECGs? Yeah. Okay, it's going to be like a quick introduction to ECG interpretation, and then you're probably going to take part into, analyzing similar strokes. Okay, and the way we do it, each one of you, or as much we can, sit here, ask the questions. For you, you're going to see this strip, and without seeing the strip, whoever sit here will give the diagnosis. Is that okay?
Okay.
Right. So basically, to read the ECG, we use a 6-steps approach. Okay. The approach is based on a simple a method, a tool to analyze it. Yeah. You can use it all the time. Without allow you not to miss a major thing. You may miss the details, which is probably going to be not as important as the major elements of ECG. You know, like shockable, non-shockable rhythm. That's important. Okay. So the way we do it is that we ask ourselves, is there any electrical activity? That's the first question. So if you look at here, for example, is there electrical activity? Yes, there's an obvious one. And then what's the ventricular QRS rate? Then we measure the rate. It's giving here 36, but there's probably, I don't know how you do the rate. I do like
interval.
how many squares divided by 300. Yeah, that's one way. If you have an irregular heartbeat, then probably you measure 15 squares, yeah, times 20. So how many QRS times 20? I'll give you the rate. Okay. And then is the QRS rhythm regular or irregular? That's important. And then is the width of the QRS normal or wide, or narrow or wide? And then we relate the QRS activity to the P, the atrial activity. Is it present? And how is atrial activity related to ventricular activity? So if we look at this ECG strip, there is a QRS activity. It's 36 beats per minute, yeah, and it's wide QRS, so that's ventricular bolus, yeah. And there's a P wave, but there's no relation between P wave and QRS. So from this I understand they are acting independently, okay? And because the QRS is wide, it means the QRS is probably ventricular generated, not atrial generated. Yeah. So that's probably the third degree block. Okay. Now, who's going to volunteer? Okay. Good. Are we okay with the time?
We have 15 minutes.
15 minutes.
Yeah.
That's it. Okay, so here's my phone. Okay, these are the questions. And I'll change the rhythm. Okay. So he's going to ask you. Yeah.
Is there any electrical activity?
Yes.
Yes.
Okay. What is the ventricular rate?
72.
Okay. Is the QRS rhythm regular or irregular?
It's regular.
Regular. Is the QRS width normal or broad?
Yes.
Within range.
No. Is atrial activity present?
Yes.
Okay. How is atrial activity related to ventricular activity?
Associated.
So this is normal sinus rhythm.
Yeah. Okay. That's an easy one. You want to come? Okay. So let's go for another step. Huh?
Because we see that.
No, that's that's supposed to be different.
Okay, shall I start?
Yeah, okay.
Well, is there any electrical activity?
Yes. Yes.
Okay, what's the rate? Ventricular rate?
54.
54. Is it regular or irregular?
Regular.
It's regular.
Okay, the width is normal or
It's
narrow or broad?
It's normal.
Atrial activity present?
Yes.
Yes.
Okay. Associated?
Yes.
So what's the diagnosis?
You tell us.
Hey, I think I've taken a mistakenly, you know? I thought they will tell me the diagnosis.
No.
So I'm going to repeat it, okay?
Okay. Now,
so-
what have you gathered from information?
So, as far as I understood, it was regular.
Yeah.
54 the rate, right?
Yeah.
Yes.
Regular 54. Associated.
Yeah. And no QRS or what normal QRS, yeah?
So this is bradycardia, I think.
Yeah. So sinus bradycardia.
Yeah. Sinus, yeah. Associated because.
Yeah, because associated.
Thank you.
Yeah. Yeah, go on.
Tell me,
Okay.
Over, I'm sleepy. Yes.
Yeah, okay.
Okay. Is there any electrical activity?
Yes.
Yes. Yes.
Okay. What is the ventricular QRS rate?
180.
180.
180.
Yeah.
180.
Yes.
Yes, 180.
Is QRS rhythm regular or irregular?
It's very irregular.
Regular. Is QRS width normal or narrow or broad?
Narrow.
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 No.
Narrow. Is arterial activity present?
No.
No.
We can
No?
see.
No.
We,
Non-sinus rhythm tachycardia. How is arterial activity related to the ventricular
There's
activity?
no.
regular, narrow, complex.
Sinus SVT.
Huh?
SVT?
Yeah, that's it. Hold on. Good job. Is that right? Okay, who volunteer? You want to come? Come on. It's easy.
Can I come again?
Can I come?
Yeah.
Repetition is the art of learning.
There you go. Just help you with the questions.
Ask us.
Is there any electrical activity?
Yes.
Yes.
What's the ventricular rate?
90.
90.
90.
Is the QRS rhythm regular or irregular?
Irregular.
Irregular.
Irregular. Is the QRS width normal?
Yes.
Yes, narrow.
Is atrial activity present?
Yes.
Yes.
Just wait.
Yes, present.
Yes, I'm present.
Yeah.
How is the atrial activity related to the ventricular activity?
Not associated.
Not associated.
Not associated.
Sometimes associated, sometimes not associated.
No, it's not. Yeah.
No associated.
So you have an irregular QRS
Even
and irregular QRS as well.
one of them.
Is it atrial fibrillation?
Well done. Yeah. Be separate. Well done. Okay. Volunteers, do you want to come? Yeah, come on. So the people stay last will have the difficult ones. I assure you.
I want to take it again.
Okay. Right.
Is there any electrical activity?
Yes.
Yes.
Okay, what's the ventricular QRS rate?
75.
Okay. Is the QRS rhythm regular or irregular?
Regular.
Regular.
Is the QRS width normal or
No.
broad?
Normal.
Is the atrial activity present?
Yes.
Yes.
Okay. How is the atrial activity related to the ventricular activity?
Associated.
It's not probably because there are three.
Yeah. 3 to 1.
Come one, 3 and 1, 3 and 1. So it's not that associated, but it's regular.
Yeah.
So what we have now, regular KRS
Okay.
and regular P wave, but it's not associated, although they're all regular.
First degree heart attack? No. Sorry.
No. We think of
Heart.
arterial. Atrial fibrillation is irregular.
Okay.
Yeah, but we have regular. That's something to do with the atrium, but it's not fibrillation. Have you heard of the SOSHAPE P wave?
Oh
The
yes,
SOSHAPE?
it's
Flatter?
flatter. Yeah.
Yeah, exactly. Okay. The confusion is difficult to diagnose confusion because is it associated or it's not?
It's difficult without seeing
Yeah.
the strip.
Exactly. Yeah.
But the shape is typical for the
Yeah. Yeah. You won't miss it.
Yes.
We're looking at. Yeah. You won't miss it. Okay. Thank you. Yeah, thank you.
second. Shall I start?
Yeah.
Is there any electrical activity?
Yes.
Yes.
What's the QRS rate?
48.
48.
Is the QRS rhythm regular or irregular? Irregular.
Irregular.
Is the QRS with normal or broad or
Normal.
No. Normal.
is atrial activity present?
Yes.
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 What's the association of atrial activity to ventricular activity?
Dissociated.
Associated?
No, it is associated. There's always a P wave before every QRS, but the
There's length.
PR is prolonging.
Yeah. Lengthening of the PR.
Prolonged PR interval.
Irregular PR.
Progressive lengthening of PR.
Progressive
Progressive
lengthening.
PR. PR interval.
So electrical activity.
Hmm?
So QRS present irregular and bradycardia
Yeah.
and normal width.
Yeah. That's probably difficult to, from there. Have a look at it and see how it is. You can see the PR interval for short, longer, even longer, and longer, and drop beat. What you call? Yeah. Winky bar, type 2. ABG. Okay, who else? Who can do easy one?
We can repeat.
Girls? No?
Shall I go again?
She's not looking at me. Okay. Come on. Have a go.
He's the clever surgeon.
Huh?
He's the clever surgeon.
Okay. Oh, have you done this or not?
Okay.
No, I haven't.
If there is any electrical activity,
Yes.
what is the ventricular rate? QRS rate?
36. 36.
30?
30.
36.
36.
36, okay. The QRS regular or irregular?
Regular.
Regular.
The QRS wide is normal or narrow broad?
Twice.
Broad.
Why?
Is electrical activity present?
P. Yes. Atrial.
Lots of electric activity.
How is electrical activity related to ventricular activity?
Dissociated. No relation.
Dissociate.
This
Huh?
time I'm right.
Third degree.
Third.
When you identify white QRS, although they are P wave, but white QRS indicate the contraction coming from the ventricle, not from the above. Yes. Okay. Right. Any questions? That's probably will be enough. Yeah.
Can you please see type 2 heart block?
Yeah. Let's go through the blocks basically. That's probably a good idea. Okay. I tell Flutter we've done it. So that's type 2, which we've done. The successive Winkleback basically. Yeah? The successive prolongation of the QS. And then there's another type of, which is type 2, second degree AV block, type 2. Yeah? And you have, is that, so there's the P wave, not followed by QoS.
Yes.
Yeah?
Yes.
But there's no pattern in that. Yeah?
No problem.
There's no pattern.
Drop it beat, yeah.
Huh?
Drop it beat.
Drop beat. But there's no pattern. It's not like 2 to 1
Yes.
or 3 to 1.
Yes.
Yeah. Well, in there, there's a pattern there. Yeah? So there are 2, 1, 2, 1, 2, 1. Yeah? That second degree heart block, 2 to 1 block.
Yeah, okay.
Yeah. That's going to be regular, while the other one is irregular. And this one, there is a complete dissociation between the ventricular and the arterial activity. That's the third degree you have here. Okay. So both this is the silence rhythm with junctional ectopics. Yeah. So there's a P wave there, P wave there. Yeah. But then suddenly there's a yeah. So yeah, there's a P wave there, and then suddenly one comes without a P wave, P wave, and then one that's junctional basically.
Does it have to be connected to the T wave?
Sorry?
Does it have to be connected to the T wave in order to be called junctional?
T wave.
Connection, relationship to the T wave.
Not necessarily. As the supraventricular. So it's at the junction of AV, I say, node junction. Yeah. That junctional rhythm. Yeah. So basically, there's no arterial activity. Yeah. But the QRS is narrow, and the rest is so the pacemaker has moved down from the SA node. I don't know what's the accelerated junctional. Let's have a look. Let's stop it. So, is this regular? Can't we,
This is
You can't put it on the screen.
yeah. I thought I'll show it to you.
It looks regular.
looks regular, right?
It's 3.5 large spurs between QRS.
No, it's irregular.
Irregular.
Wondering.
Yeah.
Inverted POV.
Yeah.
That way.
And that's why Paul is called accelerated junctional. Because if it's junctional, it will be regular. But
Yeah.
if it is accelerated junctional,
No,
that's
if
when
you
the
know
apparent path that's accelerate at the rhythm. Okay.
But if it's junctional, then I think the space between the R waves shall be somehow broader, right?
Sorry?
If it's junctional rhythm.
No, junctional will be narrow.
No, I mean the space between the R waves.
Slower.
They shall be somehow bradycardic. Yeah? If it's junctional.
What's that, sorry?
I mean, if the rate the rate was junctional on
Yeah.
the AV node,
Yeah.
that shall be somehow bradycardic.
Bradycardic?
Yes.
Not necessarily. That's
Not
that's the fastest pace maker and taking over the SA node. Yeah, because in that one, the junctional rhythm. Yeah, that's 48.
40 to 60.
Yeah, 40 60. Well, the accelerator is 52.
Yeah,
Oh, you
this-
mean the difference between the
Yeah,
two?
this one.
Yes.
Oh, you mean if the junctional should be bradycardic?
Yeah,
Well,
some.
I don't know, to be honest. Let's ask the surgeon. We can't help. No? No surgeon? Okay. BT, about the last one. And DBF.
Good shot.
What is that?
This is
Pace.
ventric paced rhythm. Paced rhythm.
Pacemaker.
Yeah.
Well done. Okay. Right. Any questions? Any question about blood gas?
I have about the blood gases. So, do we need to do the anion gap every time we have acidosis?
It's better. But the problem, the limiting factor is that we don't have chloride in the machine. And we have to send it to the lab. And that can be, sometimes takes some time.
Yeah.
I don't know why, but chloride seems is more difficult to measure than the potassium and sodium. We do a lot of sodium potassium.
So if we can interpret without the anion gap, it's okay. But if we can't, we send for the chloride and calculate.
No, if there's a normal if you can't find the reason
Source
for
of
the
acid.
acidosis,
Yes.
there's no clear acid, then you have to do an anion gap. Yeah. Sometimes, or most of the cases, history taking and clinical examination will give you a lot of information, but still probably an anion gap will help in that.
Another question about the bicarb. How do we calculate how much to give bicarb to replenish or correct acidosis if there is no acid?
Yeah. If you look at the bicarb, it's, we're talking about the extra cellular space, which is a third of the body. Yeah.
Yes.
Now, if you have the deficit, it's the normal, assume 22 or 24, and then you have 16, the measured one.
Deficit is 8.
So the 8.
6 to 8.
Yeah. So 8 times the body weight divided by 3. That's give you the amount of bicarbonate you need to give.
In milliliter equivalent.
Immediately.
And then we have
Now,
to
how
calculate
do you give it? We have different concentration. So we have 1.4%, and we have 2.8%, and we have the 8.4%. We don't give a lot of 8.4%, only in acute condition. But most of the time we give the 1.4%, we give it peripherally because the 8.4 probably you need to give it centrally. The 1.4%, 500 mils running over 6 hours and or 4 hours, whatever, quick, how quick you want to replace it. But probably it should be like slower than 4 to 6 hours. So 500 mils, 1.4 hours.
Thank you.
The 1.4% contains 140 in 1 liter, 140 milli equivalent in 1 liter. So if you calculate 6 times 80 divided by 3, 6 times 80 is 480 divided, so that's probably 50 milli equivalent we need to give. So 500 mils will be more than enough to replace that gap.